Norma Eberici and Dr. Rose, Dr. Yimpa and Dr. Bowles. I'm going to read their bio a little quickly so that you guys are familiar with who they are. Norma is an adult practitioner. She's ACP for palliative service and CHI Baylor St. Luke's and has 10 plus years of experience in palliative care. Dr. Bowles is an assistant professor at palliative care physician at PCM, having completed her medical school and residency training in the Government Medical School and her fellowship in Indiana. Dr. Eberici Onyimpa is an assistant professor of medicine at Baylor College of Medicine Geriatrics and Palliative Medicine Service Line. She provides inpatient palliative care consultation at Baylor Children's Medical Center. Her research interests are in the integration of palliative care and the management of patients with critical disease and advanced heart failure. So I'd like to welcome them to the podium.
Welcome. Our team has been working on a quality improvement project. The focus of this project is to provide nurses with the tools needed to identify when patients are in need of a palliative care consult. These are our objectives for today. And this is an outline of what we're going to be discussing today. How this concept came about was through a group of medical students. There are fourth-year medical students at Baylor College of Medicine, and they approached us regarding a national value-based healthcare competition, which is about palliative care accessibility and education. And I'm pleased to announce that they actually won third place nationally regarding this competition. So a brief overview of palliative care as it's defined by CAPC, the Center to Advance Palliative Care. It defines palliative care as a specialized medical care for people living with a serious illness. This type of care is focused on providing relief from symptoms and stress of the illness. The goal is to improve quality of life for both the patient and the family. Palliative care is provided by a specially trained team of doctors and nurses like ourselves and other specialists who work together with a patient's other doctors to provide an extra layer of support. Palliative care is based on the needs of the patient, not on the patient's prognosis. It is appropriate at any age and at any stage in a serious illness, and it can be provided along with curative treatment. This here is a perfect example of how palliative care aligns with curative treatment. Once hospice takes over, hospice will provide aggressive palliative care, typically at the end of life when patients have an estimated prognosis of 6 months or less. And this is just a side-by-side comparison of hospice and palliative care. So one of the criteria for hospice is that you have to have an estimated prognosis of 6 months or less, whereas palliative care begins at any time you have a diagnosis of a serious illness, and you do not have to be terminal to start to receive palliative care services. Where does the care take place? Essentially, the ideal situation for hospice care would be in a home setting, but there's also the option for inpatient care. In terms of palliative care, there's inpatient settings such as hospitals or outpatient settings such as clinics. Who provides this care? Essentially, it's a group of healthcare professionals that includes doctors, nurses, social workers, chaplains, and nurses' aides. And the only difference in palliative care is that with palliative care, you consult with a primary care physician to formulate a plan of care for the patients. How is it covered or who pays for this? So it's essentially insurance or Medicare. So with hospice, Medicare will provide or cover 100% of the services provided under the hospice Medicare benefit. In terms of palliative care, it's usually private insurance or Medicare. And patients usually pay about 20% of the covered services. What is the focus of the treatment? Under hospice care, the focus is on quality of life and comfort care. And it focuses on aggressive palliative care, so it treats symptoms. And it focuses on emotional and also the practical aspects of dying. Under palliative care, the focus is also comfort care, but again, it aligns with curative treatment, so patients are still seeking aggressive medical management at that time. And I will pass it on to Dr.
All right, thank you, Norma. So Norma gave you all a big overview of what palliative care is and what hospice is. And we know that I think if it's your first time hearing this, it could be a bit overwhelming. It's kind of vague. What exactly do they do? I still don't get it, right? So the goal of this QI project is really for us to meet face-to-face with nurses, for them to truly understand what we do as palliative care providers, and to understand what palliative care can provide for their patients. And there's a term called palliative care champions, right? A palliative care champion is someone who is not palliative care trained, but has an interest in palliative care and is, I would say, an advocate for palliative care. So that person, let's say a nurse, right? When they're in the unit, they see a patient, they would advocate for palliative care to get involved when appropriate. So nurses have been identified as potential and really good palliative care champions. Right? Because a lot of people don't understand what palliative care is, especially the patients. They don't know what palliative care is. When they hear it, they think hospice, right? They think I'm dying. No, right? So if we're able to reach out to nursing staff and have them understand what palliative care is, we potentially are able to have the nursing staff be empowered to collaborate with the physicians who are the attendant physicians for these patients to get us involved earlier than later. Does that make sense?
Yeah.
All right. So the goal of this is to educate nurses as to what palliative care does and what we can provide for patients. And that way, that education would empower you all to be able to say, this patient is struggling with this new diagnosis of heart failure. This patient is struggling with this diagnosis of dementia, right? Or this family is struggling to provide care for this patient. This family doesn't understand what's going on. I'll get this treatment plan. Those are the reasons why palliative care should get involved, and we really hope that nurses staff can understand that that is what we do. So you can say, Dr. So-and-so, have you considered palliative care consultation for this patient? They could really benefit from it. So the aim of our QI project was, as I said, to increase palliative care knowledge among med-surg unit nurses. Also to increase the number of appropriate palliative care referrals who make in med-surg units, due to nursing identification of potential referrals, and the important part is collaboration with the attending physicians to get this consulted referrals in. So our question was, if we educate med-surg nurses, will their understanding and the overall number of appropriate palliative care referrals increase? So for this QI project, our wonderful colleague Norma was able to reach out and collaborate and coordinate with unit managers. She also reached out to unit directors as well to say, we're doing this project, can we come to your unit and educate the nurses? And we were able to get some invitations. So far we've hit 4 units, 7 tower, 16 tower, 20 tower, and 22 tower. And the way this works, the intervention really is a rapid fire on the unit education direct our team, right? So at least one member of our team will be present along with the medical students who initiated this QI project. During this intervention, what we did was provide a brief overview of what palliative care is, sort of what Norman did, but a lot more rich. There will also be iteration of consult criteria, right? And the reasons why you will consult palliative care. And this was essentially a copy of a previous QI project that we did. This one was focused on hospitalists, right? Trying to increase their referral to our team by providing them what we call a screening criteria for palliative care. So we use that same criteria to educate the nursing staff to say, these are the reasons why you might consider palliative care consult. We just want you to be aware of those criteria. Lastly, we provided resources to the nurses. So we provided a palliative care handout. Again, when you hear this, it might be a lot, but if you're able to have a handout, go home and read it over again, it might make more sense to you. We also provided what was called a badge buddy. So, yes, a badge buddy that you can, that has palliative care screening tool that you can look at and say, oh, this patient has been in the ICU twice so far. They could use a palliative care consult. This patient has been in a nursing home for the past 2 years and is declining. They could use a palliative care consult. And this was also provided to the nursing staff. So for the presentation, we kept it very short, brief, and sweet, right? So it focused on the difference between palliative care and hospice, ways palliative care can assist in patient's care, and also which patients may benefit from palliative care. Now I'll just show you guys, this is the handout that we gave the nursing staff at these meetings. So a little bit more reading, but again, do it at your own time and at your own pace. And then this is the badge button that we provided for the nursing staff. And again, it just had a screening tool, right? This is the data from CAPC, and it's been shown that sometimes with screening tools, you can sometimes increase the earlier referrals to palliative care. So that was the goal and the hope of this QI project. And at this time, I will hand it over to my colleague, Dr. Cruz, and she will let you guys know how this worked out for us.
Thank you. So this is the badge buddy. Fits very well on your badge. Let us know if you want one. Based on that question that we had earlier, some of the things that we were looking at was where is the concept coming from? Is it coming from the unit where we've done some education, our total number of consults, and the reason that we were consulted? And this is actually data that we capture regularly. This is one version of our acute palliative care consult report that's put together by our team who captures the total number of consults each quarter that we receive, kind of where they're coming from, associated with some metrics that we regularly capture. Most notably, we're looking here kind of in the bottom middle, the source of the palliative care consult. Where are these consults coming from? ICU, cardiology, hospitalist team, which you actually have to scroll down to see there. And then the reason for palliative care consult, whether that's to discuss goals of care or treatment, symptom management, counseling and support for patients and families. Is the pre-LVAD visit? Are we discussing hospice, or is it an end-of-life situation? So we just rolled out the visits to the units really over the last month or so in mid-early November. So this graph here is the number of consults that we receive on a weekly basis in gray, and the number of follow-ups that we complete here in kind of a little bit, I guess that's a burnt orange. We began the intervention here in September. We were tracking the specific number of consults that came from those units. We were not previously capturing where, which unit each consult came from, so that's why we don't have data from before the intervention. We're hoping to see over time as we continue to roll out to additional units that we'll see these consult numbers tracking up, and we're going to see a change in that intervention line here. We also tracked the reason for consult for these units. And this is hard to say early on in this intervention, but we're cautiously optimistic that perhaps over time we're going to see this symptom management bar here continue to go up as we perhaps get a chance to be involved, not just in end-of-life scenarios, as you all heard, palliative care is helpful throughout the course of somebody's illness, and perhaps more involvement for counseling and support and symptom management. So obviously one of our directions is to continue this intervention, eventually get to everybody's unit. If you're excited for us to come to your unit, let us know. The current intervention set up for med surg units, but certainly in the future, we could adapt this for PCU and ICU units. Perhaps see the impact of follow-up education, especially as we get new nurses on each unit, or as people live around different units. And perhaps find a way to integrate this into new nurse education down the line. With that, I want to thank you guys for your attention and open this up to questions.
So I'm curious, that pamphlet looks wonderful. Is that something that you also provide to the family? Or something that we're considering doing that, or you've already been doing that?
So we do have those available that we can provide, but we would have to look to see if we have enough to go around, because I don't think we have reprinting for that. But we can get those out.
So if like a family was asking,
Yes,
and
we
they
give
were
them-
sure we would reach out to you to have that resource.
Definitely.
Is that another question? Yeah, question about the badge buddies. We do have more badge buddies. We didn't bring them with us today, though. We should have. Let us know and we can get you.
Patients that's called maybe the criteria. So sometimes we do have patients that are in recovery that really are maybe meet the criteria for the services that's
Yeah, absolutely. The criteria are pretty broad, and these are adapted from CAPC, or the Center for Advancing Palliative Care. These should all be familiar to the hospitalist staff as well, because there was, as Dr. Ananda mentioned, a prior QLAB project to make sure they were aware of this criteria too. So, thank you.
Well, we definitely can bring the batch buddies down, and we'll give it to Liv. Yeah. Okay, perfect.
Thank
So you can grab it from the team, okay? All right, thank you all.
Thank you.